So helping us connect the dots in this conversation will be Dr. Lynn Goldman, the Dean of Milken Institute School of Public Health. Dr. Goldman is a pediatrician and epidemiologist and is the Michael and Lori Milken Dean and Professor of Environmental and Occupational Health at the Milken Institute School of Public Health at the George Washington University. Dr. Goldman is a renowned expert in pediatric environmental health and chemicals and pesticides policy. She has engaged in translating research to policy through writing policy analysis and via congressional testimony in service of successful efforts by Congress to achieve passage of reforms both to federal pesticide law and federal chemicals law, as well as legislation to establish California's childhood lead poisoning prevention program. Also joining us today is Dr. Cara James, President and CEO of Grantmakers in Health. Dr. Cara James is President and CEO at Grantmakers in Health, and prior to joining that organization, she served as Director of the Office of Minority Health at the Centers for Medicare and Medicaid Services, where she provided leadership, vision, and direction to advance the U.S. Department of Health and Human Services and CMS goals related to reducing disparities and achieve health equity for vulnerable populations, including racial and ethnic populations, persons with disabilities, sexual and gender minorities, and persons living in rural communities. Under her guidance, CMS developed its first CMS equity plan to improve quality in Medicare, its first rural health strategy, and created an ongoing initiative to help individuals understand their coverage and connect to care, increase the collection and reporting of demographic data, which we learned through COVID was extremely important, and develop numerous resources to help stakeholders in their efforts to reduce disparities. Also joining us today is Angela Franco, the President and CEO of DC Chamber. Prior to joining the DC Chamber of Commerce as President and CEO, Angela Franco was a Senior Advisor for Business Development at the DC Health Benefit Exchange Authority, where she was responsible for collaborating with the Hispanic and business communities, as well as local and federal government. Angela has served on numerous boards and commissions here in DC and elsewhere. She is a board member at large for the United Way Capital Region and the advisory board of the Pan American Development Foundation, and an appointee to the DC Workforce Investment Council. Dr. Hugh Mighty is Vice President of Clinical Affairs and Dean of Howard University College of Medicine. Dr. Mighty received a Bachelor of Science degree from Georgetown University, his medical degree from the University of Maryland, and his MBA from Loyola University in Baltimore. He has served in multiple academic leadership positions, including chairman of the Department of Obstetrics and Gynecology at the University of Maryland, where our paths crossed. And he is chair, Dr. Mighty trained and mentored more than 200 residents and fellows, as well as recruited clinical and basic science faculty. Dr. Mighty served as Vice Chancellor for Clinical Affairs at Louisiana State University and LSU Health Sciences Center in Shreveport, Louisiana. During his tenure at LSU, Dr. Mighty guided the financial and strategic direction of the academic and hospital enterprise, including 3 safety net hospitals in the state. He is known for developing innovative statewide programs such as the Tomorrow's Children program that deferred incarceration for pregnant women with minor offenses in exchange for the development of job and parenting skills. And Dr. Mighty has also served in multiple public leadership roles, including chairman of the State Commission on Infant Mortality Prevention for the state of Maryland. So I want to thank all of you for making the time to join us for today's discussion. And I would like to remind our viewers and participants that they can join the conversation by posing questions on the Run the World platform or by tweeting at DC Health and tagging us on Facebook. Let us know how anything you hear today resonates with you and your community, and let's just jump right into the conversation. So I'm going to start by inviting all 3 of you to share with us your thoughts on our first question. We know that the COVID-19 pandemic has impacted us all, and it's impacted us all in very different ways. I'm primarily interested in your perspective as leaders of organizations, and often leaders of large, complex organizations with their own personality and their own culture. And fortunately for us, organizations that have an impact on our community in a very meaningful way. So can you tell us how the pandemic has impacted your organization, how you function, the people in your organization, and specifically how the pandemic has changed how you as a leader view your organization's role in our community. So we'll start with you, Angela.
Yes, well, good morning. Thank you so much, Dr. Nesbitt, for inviting me and representing the DC Chamber of Commerce. You know, I started as the CEO in the middle of the pandemic, and we had to shift as an organization. And for the business community was the struggle between going back to business, going back to work, and really keeping the community safe and being healthy. I'm a big believer in following instructions, so we write very closely. So anyway, we wanted to do whatever direction came out of the Department of Health. And we had a lot of struggles on the way for that reason, because people want to go and produce. Some people were losing their jobs. Some businesses were closing. So it was a struggle all along, and little by little, we walked them through. We worked together with the business community to set up some strategies that would help businesses move, some other redirected their purposes or started creating other kind of businesses. So that worked out. I mean, it worked its own course, and now people are coming back little by little to work. As a leader, it was really a personal confrontation and a professional confrontation. I had a son at home that is 12, and he attends special education. So having him at home was I'm not going to say a struggle. It was really like kind of a reality check for me as a mother. And as a leader, I've always been a leader that cares about the employees, that cares about their well-being, and that cares about my own health, because that's the only way I'm going to be able to help my son and help my community. So it's something that I've been stressing all along since the beginning, especially dealing with the business community. You're not in contact all the time with the health issues, and that's a conversation that needs to continue. So it is important for us as leaders to stress the importance of keeping our employees healthy, of keeping ourselves healthy, and understanding that health is part of what we do. I have to admit that the conversation around health is more often, and is something that comes up a lot in our conversations. And we always ask ourselves, how are you doing? Or how's your family doing? And maybe something that we didn't do in the past. We did a study with DC Health in terms of what companies are doing to keep their employees healthy. And there's a lot of room for growth. So it's something that we have in our minds. It's very clear to us that we have to continue to stress these and to make sure that we keep our communities healthy.
Yeah. And Cara?
Yes, so thank you, first of all, for inviting me to be part of the conversation. It's great to be joined by such great panelists. So we, as you mentioned, lead Grantmakers in Health, and we are celebrating our 40th anniversary next year. So we work with health foundations and corporate giving programs across the country, so very much focused on health and how they respond to their communities. So I know we're going to talk a little bit more about specifically what philanthropy has done in this time, but I also joined Grantmakers in Health right as everything was beginning to kind of close down in the DC area. So that March 11th was my first official day on the job, and really quickly had to learn about an organization and figure out what we were able to do and how we were going to help philanthropy navigate through this space and help our communities. So some of the things that we did as well, Grantmakers in Health has had a long focus on health equity. And as you were doing the introduction, that is something that I've spent my career focused in. So immediately pivoting to help them respond to that. Very much thinking about staff and a staff who didn't know me or how I would respond to different things. But I will say, coming from CMS, where we deal with crises and things not on this nature, but you deal with earthquakes, hurricanes, things like that, and how you respond was actually helpful in being able to help the organization navigate through a very contentious time. But thinking about staff, making sure they had the resources they needed to be at home, to be able to be effective, and also thinking about what our organization's response is going to be and what we feel like we need to be doing to help lead. And I think for a number of philanthropy support organizations, which is what we are, a lot of us are questioning and thinking about what is our role in advocacy and policy, because as we know, that also is so important to the outcomes that we're all trying to achieve and affects our ability to do the work that we're seeking to do. So those are some of the things, and I know we're going to talk more specifically about how philanthropy has responded.
Absolutely. Yeah. So a great time for us to be very thoughtful and reflective about mission, vision. Are we really the mission-oriented types of organizations we want to do in not only our daily operations, but how we're structured and operating in both intrinsically and extrinsically? Hugh?
Again, thank you for allowing me to be here. I would say two things unfolded in the pandemic that really came front and center for us. We are, of course, at Howard, are a service-oriented educational institution. And the two things that came that certainly changed our position is the understanding of how mobilizing a force for service. We have 4 health sciences schools, nursing, dentistry, pharmacy, and the medical school. We have residents, and we mobilize a force to immediately go out into the community and begin to do testing when testing was available before vaccines. When vaccines became available, we did the same thing. And we really were able to marshal a force of people to deliver service. This wasn't just about being, a doctor at the bedside. This was about nursing students, about medical students, all the way up to faculty to reach out to the community. But I think the real lesson learned in part of that service was educating, not just educating us, but educating the community. I mean, we got a chance to talk to people, and which you normally, a lot of times when you're training, you're in your big castle tower. Being out in the community, understanding some of the challenges. What happens, for example, while we were testing, is the idea that there are lots of people with healthcare disparities out there in the community with, diseases. They can't get a bus to get care. So the question became different. Can we mobilize? And we had to pivot very quickly, for example, to delivering telehealth, something that we hadn't really been done in small part, but now it had to become a routine part of what we did. So getting services out and beyond our campus into those communities gave us a chance to bring that back even now and integrate that into what we do today. So we're much more mobile. We're much more involved in getting out into the community and delivering care, but not just care. Even as the vaccines come along, education. I got a greater appreciation for not just educating our students, but to educating the public as to why, what is the importance, addressing issues around myths and fears, a different kind of teaching that brings expertise, yes, but brings really a community feel, talking to your own family that's beyond your borders. And I think that has really stuck with us and changed in large ways how we lead and how we think about training the next generation of.
Yeah, I think, you've touched on something that I think we'll hear quite a bit today. And we've heard this in conversations with some of our colleagues. It's this notion that a lot of leaders found opportunities to accelerate innovation. Right, when we would find reasons to not start something, right? We knew it was a good idea, and we knew that it was something we maybe wanted to do. And we can sometimes be the city of pilots, right? We're going to pilot this, and it works, but something stops us from bringing it to scale. But the pandemic really created opportunities for acceleration of innovation and bringing some of those pilots to scale and permanently integrating those new technologies into the way that we do business. So it's exciting to hear you say that. Lynn, let's hear from you.
Thank you very much, Dr. Nesbitt. Being a dean of public health, I'm an employer, and so we've had many of the same experiences with having to take care of our own employees. We have thousands of students, the responsibility of caring for our students, and then we have a responsibility to the community, not just in DC, but also in other contexts nationally as well. And so it's been a very challenging time, and a time when part of what we've needed to do is to be very clear about communications, about using the epidemiology, the knowledge that we have about virology, immunology, to hopefully provide a voice of sanity, to go through a lot of the miscommunication, and some of which has been deliberate in the pandemic. But we've also needed to do a lot of work right at home, good old epidemiology, applying that. I know often working with your staff in DC Health, but also Maryland and Virginia health departments, and on our own campus. We were able to gain a contract to work on the Moderna trial. I think that was very important that we were able to do a clinical trial of the vaccine in our community among people in the community who are often not represented in clinical trials. I think that was extremely important to be able to demonstrate the safety and efficacy of the vaccine in that population. All of that, I think, built on the fact that we had a solid base of work that we had already been involved with, much like Howard, where, we had worked closely with DC on HIV/AIDS. We're already doing clinical trials on HIV/AIDS prevention and could key into that work and the communities that we were already collaborating with in order to be able to further that in the context of COVID. We would have never been able to develop those relationships mid-pandemic. I think that there's a lot that we learned about health disparities that's important, not just the numbers, but the systemic nature of disparities and how institutions like our own are involved in helping to create those and have a role in helping to take those apart. And that's a place where I think we have a responsibility to do a lot of work. In the future, we could talk about that a little bit more, Dr. Nesbitt, but I do think that the systemic nature of the health disparities in our society and the places in the system that are responsible for them, that's where we really need to dig in, certainly as a school of public health, but also a health provider in DC.
So, you've got a big role over there at GW, and you've been the dean at GW in one of the best schools of public health in the country. And you have some great partnerships on that campus. There's a medical school there, lots of resources at the university. And you've talked about the ability for those resources to be mobilized to tackle some of our really long-term challenges that we've had in DC. And GW is undoubtedly a national leader as well when it comes to health policy. So this summer, DC Health released our COVID-19 health and healthcare pandemic recovery report that outlines how we want to, or how we think about what the recovery pathways need to look like for the city moving forward. One of the key areas that we've identified for an area of investment, an area for strategic focus is workforce, right? So this is really going to have to be a core element for the plan. As we think about what public health education and training has looked like historically, and we've all embraced this tenet of doing the greatest good for the greatest number of people for the longest time. And I talk about that a lot around here when we're making policy decisions and program decisions. That's often a guiding principle for us. How does this, is an equity-focused approach to public health education and training for the current workforce, right? So we're always doing continuing education. So for the current workforce and for the future public health workforce, is it in line with this philosophy of doing the greatest good for the greatest number of people, right? So how does equity align with that? Or how does the current curriculum, and capstone projects that students have a commitment, if you're in a master's program or even some of the bachelor's degree programs that are coming up for public health students now, how do we structure that curriculum and those capstone requirements in public health education now to really foster some scholarly activity for students who want to be involved in the non-traditional aspects of public health that now embrace things like violence as a public health issue and racism as a public health issue? How are you thinking about those types of approaches over there at the School of Public Health and on the GW campus more broadly?
Well, let me. There's several things. One is that there is a tremendous.
Sorry, Lynn, give us 1 second. Dean Goldman. Yep.
Okay, am I on now? Okay. So number one is that there's a tremendous inequity in the kinds of exposures that people have. And we saw that with COVID, the fact that some could stay at home and protect themselves during the time before we had a vaccine, and others who needed to keep going out and working, right? But we see that with cancer-causing agents. We see that with poor nutrition. We see that with any kind of exposure that is leading to not only an infection, but also a chronic disease, the inequity of exposures. The second thing that we have is that we have delays in access to care, that people don't come in for care soon enough whether it is for their COVID or their cancer, and the impact that has on their ultimate treatment. We have alternative pathways that people have in terms of providing the care. And in particular, I think some enormous problems, historical problems around communication and trustworthiness of the healthcare system for people coming from disparate backgrounds that we need to address. And we, public health, need to understand where those factors come from and work to ameliorate them as best as we can. But fundamentally, although public health is always focused on health equity, identification of disparities, I think in the past we've been more focused on documenting and quantifying disparities, tracking disparities, than getting down into the root causes of them. And where those have to do with differential exposures, frankly, where those have to do with racism and the negative impacts of racism on health, we need to teach our students about that. That needs to be incorporated in public health training. We need to learn how to elucidate that in both the research that we do, but also in the practice as we're going out in the communities. And as you point out, Dr. Nesbitt, as our students are going out into the community and doing their practica. I would also say that in addition to addressing, the curriculum, we have to make a stronger commitment to the faculty and developing our faculty, and that they have the teaching skills. We have been attracting a wonderful, diverse pool of students who sometimes, and they come to me to talk to me about this, they find themselves in a situation where they want to have a different kind of experience in the classroom. And so we've been addressing a lot of attention to teaching the faculty about how to address the information, the knowledge that our students want to receive. But at the end of the day, whether it is public health workforce, the nursing workforce, it's clear we need more people in the health workforce. The COVID pandemic has pointed out the shortages that we've had, and some of them are getting even worse because of the burnout that people are experiencing. And so I also feel a tremendous responsibility to bring the students through the process, figure out a way to, as quickly as possible, help to replenish that workforce, because that is going to be an absolutely critical need moving forward.
Absolutely. Thank you so much for your thoughts on these topics. I think, it's been so critical for us to be able to share, especially, and, I can see and hear Angela nodding as a member of the Workforce Investment Council, that as we think about what the workforce needs to look like, as we're thinking about training opportunities and exposure for our youth in the district being career ready, that we want them to be able to understand the diversity of opportunities that exist in health. As you've put it, whether careers in public health or healthcare, there's a diversity of opportunities that exist there, and we want to make sure that people understand what those look like. So let's kind of stick with this theme, Dean Mighty, of the role of academic institutions, either in training or other things, because I think you can add some diversity of perspectives here. And with our health equity report that we released in 2018, and we've talked about this quite a bit today, where that report highlighted that healthcare itself was just one aspect of it. And over there on Georgia Avenue, there's lots of bustling activity related to Howard University, right? So there's the matter of this one thing called the hospital, but then there's lots of other things that happen on that campus. And we're recently partnered with Howard University with the Centers of Excellence. So there's lots of other investments and activities that are happening on that campus. So what role can academic institutions like Howard University play in addressing the other key drivers of health, such as education, economic development, housing? How important is it for historically Black colleges and universities to play such a role in cities like DC in addressing health equity and these other sort of 9 key drivers?
And thank you for the question. I think it's a great time to point out that Howard University is our university. It's not just the medical school. It is a university that has law school. So when we talk about justice, social justice, it has a school of social work. We do have a public health program, not a public health school, but again, we vibe all those things. We have architecture and engineering around how do you design housing, how do you design access points for folks who otherwise may not have that ability. So I think we have the ability now to leverage what I think is the team of science to bring towards, if the endpoint is healthcare is, health outcomes is the endpoint, right? Without housing, without jobs, without access, easy access, without education for the public. And I don't mean necessarily you go out and get a degree, but just, the one thing I've learned this year that, again, as an institution, as a university, we can do is to help our trainees, our students learn how to educate others and build trust. Because building trust in those communities allows you to take your expertise into the communities. And as Dr. Goldman pointed out about things like vaccine, we're part of a vaccine trial. And I remember that when we stepped into that, we were late to the game, right? Moderna had already closed out their trial. We started a trial with Novavax. We were able to, in a matter of weeks, get caught up with our numbers. And I look back on it and I thought, what is that? What that is trust, is communication. And so you take that backwards for a moment and you look at something like the Centers of Excellence. There are 5 key points to start with in terms of sickle cell and trauma and violence. But all of that allows us to go back into the community and to start training others to take care of things. I think that it's one thing to have expertise, but if we can train not only our students, but also to bring the community in almost as lay people experts, you can address violence in schools, right? To go into not just teachers, but community folks. If you can get community folks to engage pregnant women early on, right? You're going to identify points before they get to the healthcare system. So I think leveraging our entire scope of the university that we have, which is pretty formidable, we're going to be able to look at outcomes and disparities in a very different way by harnessing, is it a legal issue, or is it a medical issue, or is it just a matter of social work and jobs training, right? And we can access all of those things. And each of our schools now do something in that manner in the community. So the Centers of Excellence is going to give us an opportunity to actually develop not only healthcare models, but also workforce models as to who can go out and deliver and expand on that. It's an investment, right? I look at it as being, it's an investment, but hopefully we don't just use it for clinical scientific research, but we actually build educational support models across the board.
Absolutely. And we're very excited about the Centers of Excellence, and, how partnership with Howard for that was precisely that reason, the opportunity to work across all of those different sectors and institutions, schools and programs within the university, and to really do that type of integration in terms of how people live, right? So people don't wake up and only want to deal with the parts of their lives that need education or social support, et cetera. They want to be treated as whole beings. And so the university has the ability to design and develop programs and initiatives in that way. And you've hit on what some people keep putting in the chat, health literacy, right? Talking about how we really began to do this thing of community education and getting out there and having people have ownership for their health in ways that is really community-led and community-driven. So, Dr. James, let's talk about money, right?
Back to the chamber.
Yeah, we're getting lots of historic investments in health, and it's sort of been on a trend for the past 10 years or so. There was the passage of the Affordable Care Act, which often gets a lot of attention because of the insurance aspects of the Affordable Care Act. But there were lots of seed funding for lots of other initiatives in it. But with COVID, some people really began to pay attention to what public health infrastructure looked like in the U.S. and our ability to respond to pandemics. But also these very real things about what the public health and healthcare workforce looks like in our country. And some surveys that were probably done 5, 10, 15 years ago are now getting more traction. But there's not only investment from the federal government, there's investment interest in programming and policy interest, as you mentioned, from a lot of other places. So how are foundations and philanthropic organizations thinking about future investments in health? And can we expect to see a shift in the types of investments that are made in order to advance equity and anti-racism focused initiatives in our community and in the region?
Yeah. So, great questions. And I think that I'll start in a couple of spaces. One, just to back for just a second on the equity space to say that there's been a lot of investment in that space. And that is one where we've seen a burgeoning of interest. And I think that it's really good, but it's also a little concerning. And I say it's concerning because there isn't necessarily a clear roadmap on what we need to be doing to make sure that our investments amount to meaningful change when this window of opportunity closes. And I say it's a window of opportunity because we are easily distracted as a country and other things. And so we hope that this window will remain open for a long period of time, but we have a history. We have a history. So I think making sure that people have common definitions. What is it when we talk about health equity? This is not the time to invent your own definition. There's some well-established ones. Having clear guidance in those cross-sector collaborations, as we've talked about health, housing, food, transportation, those are things that are not necessarily medical, but they are things that we need to address in order to achieve health equity. So how do we work collectively? And as I say, become a little more bilingual and multilingual so that health can talk to education or talk to business in a way that fosters those collaborations. But to answer the question around philanthropy and what philanthropy has done, philanthropy is always there to respond and step in where there's a need. And what we saw during the pandemic and what we have seen, philanthropy immediately responded to focus into community, providing PPE, providing testing, helping with transportation, helping food as kids transitioned home and some of those food supports changed. And we are continuing to see as well that philanthropy responded by removing some of those restrictions around reporting so that the money could also be used for whatever was needed rather than specifically what it was provided for. So when we think about that as that trust-based philanthropy, giving that money to the organizations to do what they feel is best needed rather than prescribing what that is looking like, going back to your point about spurring innovation, we're seeing more philanthropic organizations move closer towards that trust-based philanthropy. I think we also think about philanthropy from that power sharing and working with community rather than a paternalistic model of telling community what needs to be done. And so a lot of organizations, again, some are on that journey further along the path. Others are moving further up that stream there and looking at that. So how do we work with community, recognizing that community has a lot of expertise about what the problems are and what the solutions are that are actually going to work in that community as opposed to another community. So we're seeing that as well. And then I think what you're also seeing, which is not unique to philanthropy, everybody's focused on diversity, equity, and inclusion. And we've seen the creation of substantial numbers of health equity positions. And I think making sure, again, that we provide the supports and resources that those organizations, those individuals or groups need in those organizations to be successful so that they're not set up for failure, if you will. So how do they have that resources needed to address health equity? I think we're also seeing with the American Rescue Plan Act, huge investments into community, and philanthropy is very much watching that and trying to figure out what is the role, because despite all the money that philanthropy has, it cannot compete with government in terms of that. So making sure that the lanes are clear of this is government's function, this is philanthropy's function. How do we work together and support? But also, what are those spaces, the gaps that haven't been addressed? So I think we will see continued change in that space. And I think the other thing I would just lift up that is not unique to philanthropy, but everyone is looking at as well. How do we diversify the leadership of those organizations, thinking about boards of directors, thinking about leadership within philanthropy to look a little more like the communities that we're trying to help?
Yeah, well, that's an excellent point. And you know, there's a couple of pieces I've read recently where we talk about the diversity, equity, and inclusion movement and how we think about the DEI movement from the workforce and diversifying leadership, but also being very intentional about the DEI initiatives, right? There's a separate thing to be focused on diversifying the workforce and having specific equity-focused initiatives that have equity-focused outcomes, right? Yep. Now, there's a link between the two. Right. And we've known for a long time about concordance and the patient-physician relationship and how that improves outcomes. But there's a distinct commitment that has to be made to both if we're really going to make make some progress here. So let's turn to you, Angela, and let's talk more about what the business community is doing in terms of a commitment to equity. And so we know about these 9 key drivers that we've identified in the health equity report, and we know that economic development and education and income are really critical parts of that, and how we educate our workforce and all of those things, and having a thriving business community is really important. We also know that when we set out to start talking about post-pandemic recovery, when the mayor first brought people together, I think it was in April of 2020, is when we started planning our recovery, and we were focused on health, opportunity, prosperity, and equity, our hope. Was our theme there. Can you share with us a little bit about what the business community is doing to be focused on equity, or in specifically health equity, as you all are having your discussions in your strategic session?
Sure. So the first thing I want to say is that I've been very grateful to be part of this conversation. And, the world of the business community has a long ways to go in order to connect with health. So when we're talking, for example, about workforce development, we are working very closely with education and really incorporating the health components, because we believe that, long-term, having a healthy and an educated workforce a workforce is very important for the community. In terms of the chamber, we have a strong health and wellness committee. We always talk to the employers, but I really, really see that there's a long ways to go, and we really have to work closely with health and continue to educate companies, continue to educate employees. And this conversation has been, as you were all speaking, and I was nodding my head, as you said, for me, it was like, I'm in complete agreement with what you all have shared. And I wonder how we can translate that more in depth into the business community. It's not like not everybody's not conscious about health. We talk about it, but not as in-depth as we have had this conversation today. And I think continuing those conversations, getting more involved with the business community, and the business community also understanding that health is not, it can start basic, really helping the employees with a basic platform, right? They don't have to become experts in health, but really work with somebody that is an expert in health. I think that equity and diversity and inclusion is a conversation that we're also having in many fronts, on the employee side, so that everybody has equal opportunities regardless. And I still see that in the workforce, people are not open about sharing what they're going through. So there's some, like the large companies that have the budget, they have a line where people can call and say, this is what's happening, or talk confidentially with somebody. But, 90% are small businesses, and they don't necessarily have those tools. And that's where I think we really need to work together in creating those spaces for people to be able to share what's going on in their lives. It's just the healthier they are, the better contributors to the society and to the business community they are. So we are, as an organization, we're extremely committed. As I said, we have a health and wellness committee. We had done a study with DC Health to understand what companies are giving support to businesses and what kind of additional support we can give in terms of health and wellness, and, making sure that our immediate circle is conscious of their health, like the employees, the board, me as a leader, and with the other leaders in the business community. But I would love to, and I would welcome continuing, the conversation, and most importantly, is that you help us as the business community to understand how best we can educate people. We are experts in business, so that's why this conversation has been so powerful for me. So I know I'm a little passionate about it right now, but it has been very powerful for me, because for us, we also need tools to be able to educate people. Not so much saying, oh, they're not doing enough. Maybe we don't know exactly how to do that process. And if we get tools that we can help, basic tools, maybe we can really make a difference in the people we serve.
Absolutely. Well, I want to thank all of our panelists for joining us today. This has been a completely informative session. I also think it's been a completely inspiring session. We all know that the path to health equity and equity broadly, racial equity, is going to be very long. We didn't arrive to the inequities that we have in this country overnight. They have been historical. The injustices have been historical for hundreds of years, and we're going to have a very strong and solid and sustained commitment. The quote from Dr. Thatcher that talks about our need to have perseverance to be able to tackle these things is extraordinarily real and should resonate with all of us. But we definitely have dynamic leaders who are here with us today, Dr. Lynn Goldman, Dr. Hugh Mighty, Dr. Cara James, Angela Franco. We want to thank them for their time and thank them for their continued commitment. As we transition in our program, we want to remind all of you that we're going to have more panelists this afternoon. We're going to have more thoughtful discussion this afternoon and more engagement. But now we're going to transition into a 30-minute lunch break, and we will return at 12:30.